Welcome. In the previous session, we discussed about infantile esotropia and accommodative esotropia, the two most common forms of esotropia in children. In this session, we will be discussing the remaining types of esotropia which can occur in children as well as in adults. And these include acquired comitant non-accommodative esotropias and incomitant esotropias. In acquired comitant non-accommodative esotropias, we have several entities, and these are characterized by being comitant, that is, the deviation measurement is the same in all positions of gaze, onset after 6 months of age, which includes a period from later infancy to as late as adulthood, and absence of activation of accommodative convergence either due to high hyperopia or a high AC by A ratio. Since in an acquired esotropia, the patient had binocular vision prior to the onset of esotropia, possibility of restoration of high-grade binocular vision following surgical realignment of the eyes is good. In basic esotropia, the esodeviation is similar for distance and near fixation. Basic esotropia can be acute in onset, and children with acute onset of esotropia can complain of diplopia before suppression sets in. Basic esotropia can occur following temporary but prolonged disruption of binocular vision, such as due to prolonged patching, hyphema, or mechanical ptosis, or can occur following prolonged near work. Treatment of basic esotropia is realignment of the eyes soon after diagnosis, either by surgery or with botulinum toxin, and followed by amblyopia therapy if required. In basic esotropia, prism adaptation study showed a lower rate of undercorrection when the amount of surgery is based on prism adjusted deviation. We have discussed prism adaptation in the session on sensory evaluation of a Strabismus patient. Cyclic esotropia is a rare entity, and cyclic strabismus patterns other than esotropia are even rarer. Cyclic esotropia occurs in early childhood, typically in the preschool years, and cyclic esotropia is characterized by intermittent esotropia, in which there is 12 to 36 hour periods of orthotropia alternating with 12 to 36 hour periods of constant large angle esotropia. Unlike the intermittent esotropia in the early stage of accommodative esotropia, the cycles in cyclic esotropia are strictly repetitive, and esotropia cannot be induced by monocular occlusion during the orthotropic period in cyclic esotropia. During the esotropic period, binocular function in the form of fusion and stereopsis is disrupted, and patient demonstrates abnormal retinal correspondence and suppression during the esotropic period. But in the orthotropic period, binocular function is normal. Most patients with cyclic esotropia ultimately decompensate to a constant esotropia, and patching can convert a cyclic esotropia to a constant esotropia. Management of cyclic esotropia is surgical correction, and it is based on maximum angle of deviation during the esotropic period. Sensory or deprivation esotropia results from monocular vision loss, which can occur from cataract, corneal opacity, retinal and optic nerve disorders. Correction of the cause, if possible, should be performed as early as possible to prevent amblyopia, and if strabismus surgery is required, it is usually performed only on the defective eye. In divergence insufficiency, esotropia is characteristically more at distance fixation than at near fixation. In contrast, in basic esotropia, the magnitudes of deviation at distance fixation and near fixation are similar. Although in divergence insufficiency esotropia is more at distance, this esotropic deviation remains horizontally comitant. That means the magnitude of the esodeviation remains similar in the horizontal positions of gaze for a particular distance of fixation. Divergence insufficiency patients usually have reduced fusional divergence amplitudes, which contributes to the divergence insufficiency for distance fixation. Three patterns of divergence insufficiency have been recognized in primary adult onset distance esotropia, also called sagging eye syndrome. Individuals over 50 years of age complain of slowly progressive horizontal diplopia in the distance, with the diplopia disappearing on near fixation. This occurs due to thinning of intermuscular septum between the lateral rectus and the superior rectus muscles, and orbital imaging in these patients have also shown lengthening of the lateral rectus muscle. As a result, there is weakening of the lateral rectus muscle and the eye becomes esotropic. These patients can be treated with base-out prisms, that is, the prisms are oriented with their apex towards deviation, botulinum toxin injection to medial rectus muscles, or surgical correction of the esotropia. The second pattern of divergence insufficiency is the primary distance esotropia associated with myopia, also called heavy eye syndrome, in which the posterior portion of the globe prolapses between the inferiorly displaced lateral rectus muscle and the nasally displaced superior rectus muscle. Associated hypotropia of the eye can also be present, and this occurs in younger individuals with high myopia and is often associated with prolonged near work. The third pattern of divergence insufficiency is secondary divergence insufficiency, a rare entity which can occur with intracranial lesions such as pontine tumors, raised intracranial pressure, or following severe head trauma. Secondary divergence insufficiency is probably due to a mild sixth cranial nerve palsy, and because of this, we may get incomitants in these patients. Spasm of near reflex is also known as ciliary spasm or convergent spasm, and patients with spasm of near reflex is often found to have stress, anxiety, and other psychological issues. Rarely, spasm of near reflex can be associated with CNS lesions. In spasm of near reflex, there is overactivation of the near response, with the patient demonstrating varying combinations of excessive convergence, meiosis, and excessive accommodation. The myopic shift of refractive error occurring with the excessive accommodation during the spasm is called pseudomyopia. And characteristically, on horizontal version testing, patient shows convergence movement with limitation of abduction of the abducting eye instead of a normal version movement of both the eyes. On monocular duction testing, however, full abduction of each eye can be demonstrated in patients with spasm of near reflex. Management of patients with spasm of near reflex is mostly non-surgical, with cycloplegics such as atropine or homatropine, cycloplegic refraction, bifocal glasses, and psychological counseling. Botulinum toxin or surgery is rarely needed and should be done with caution in these patients. In consecutive esotropia, patients having a history of exotropic deviation demonstrates esotropic deviation, and consecutive esotropia can be of two types, either spontaneous or post-operative. Spontaneous consecutive esotropia is a rare entity and almost always is associated with either neurological disorders or poor vision in one eye. Post-surgical consecutive esotropia is more common and occurs following surgery for exotropia. This consecutive esotropia can be due to the targeted small overcorrection, or due to a slipped or a lost lateral rectus muscle, or over resection of medial rectus muscle during correction of exotropia. And these two entities can be differentiated by force duction testing, which will show absence of resistance to abduction in consecutive esotropia due to a slipped or a lost lateral rectus muscle, and presence of resistance to abduction in consecutive esotropia due to over resection of medial rectus muscle. Consecutive esotropia due to the targeted small overcorrection or due to over resection of medial rectus often disappears spontaneously, but the consecutive esotropia due to slipped or a lost lateral rectus muscle needs to be intervened with immediately. Esotropia is the most common form of strabismus associated with neurological disorders. Esotropia associated with developmental neurological disorders are usually intermittent, can be variable or stable, may worsen to a constant esotropia, and may disappear with maturity. Among children presenting with acute onset of acquired comitant esotropia, only 6% have associated neurological disorders such as intracranial neoplasms, Chiari malformation, and hydrocephalus. And there are several signs suggesting possibility of associated neurological disorders in esotropic patients and thus demands neuroimaging, and these include divergence insufficiency, spasm of near reflex, recurrent attacks of acute acquired comitant esotropia, spontaneous consecutive esotropia, incomitance and palsy of the sixth cranial nerve, abnormal head position and headache, and signs of non-ocular neurological deficits. As we have discussed previously, a deviation is said to be incomitant when the magnitude of the deviation varies in different positions of gaze. Incomitant esotropia can be due to palsy of the sixth cranial nerve leading to weakness of the lateral rectus muscle. But most cases of suspected congenital sixth cranial nerve palsy are actually patients with infantile esotropia having cross-fixation and demonstrating pseudo-abduction deficit, as we have discussed in the previous session. Otherwise, congenital sixth cranial nerve palsy is a transient phenomenon. Sixth cranial nerve palsy in childhood is most commonly due to post-viral or post-immunization inflammation, but 1/3 of childhood sixth cranial nerve palsy are due to CNS lesions such as head trauma or hydrocephalus, and so neuroimaging is recommended in childhood sixth cranial nerve palsy. In adults, sixth cranial nerve palsy is mostly microvascular in origin, but less commonly can be due to CNS lesions such as raised intracranial tension and cerebellopontine angle tumors. Apart from sixth cranial nerve palsy, other causes of incomitant esotropia include medial rectus restrictions, which can occur with thyroid-related ophthalmopathy, orbital myositis, medial orbital wall fracture with entrapment of the medial rectus muscle, excessive medial rectus resection for correction of exotropia, and long-standing CCDDs such as Duane's and Mebius syndrome. CCDDs are congenital cranial disinnervation disorders, which we will be discussing in the session on special motility disorders. Esotropia associated with high myopia, which we have discussed earlier in this session, can also be incomitant, and orbital implants such as scleral buckle and glaucoma drainage devices can also cause incomitant deviations. Treatment of incomitant esotropia include patching to prevent or treat amblyopia, prisms to correct diplopia in primary position, and botulinum toxin injection to ipsilateral medial rectus muscle. Surgery for incomitant esotropia should be done only if the palsy does not spontaneously disappear 6 months after its onset, and this is a very important figure to remember, that after onset of an incomitant strabismus, we must give at least 6 months for the incomitant strabismus to disappear spontaneously before we plan a definitive surgical correction of the incomitant strabismus. In partial palsy, where some residual strength of the lateral rectus muscle exists, horizontal rectus muscle surgery is performed. But in complete palsy, in which there is no strength in the palsied lateral rectus muscle, vertical rectus muscles are transposed to the palsied lateral rectus muscle, and we have a separate session to discuss various types of surgeries on extraocular muscles. As discussed in the previous session, several nystagmus patterns are associated with esotropic deviations. Fusional maldevelopment nystagmus syndrome, also called latent nystagmus, is found in 50% of patients with infantile esotropia. Nystagmus blockage syndrome is found in 10% of patients with infantile esotropia, and Siancey syndrome is a specific form of infantile esotropia in which we also find abducting nystagmus. Now we come to a diagnostic algorithm for patients with esotropia. We first try to find out whether the esotropia is incomitant or comitant. If the esotropia is comitant, we then rule out if there is any monocular visually significant lesion. which will label the esotropia as a sensory esotropia. If the esotropia is comitant and there is absence of monocular visually significant lesion, we try to find out if there is reduction of the esotropic deviation with correction of the refractive error found on cycloplegic refraction, which will label the esotropia as an accommodative esotropia. If there is reduction of esotropia with refractive error correction, then we have to find out whether there is any residual esotropia at distance after correction of the refractive error, which will label the accommodative esotropia as only partially accommodative. And if there is no residual esotropia at distance with spectacle correction in a patient with accommodative esotropia, we try to find out whether the near esotropia and the distance esotropia are similar. If the near esotropia is more than 10 prism diopters than distance esotropia, and these near and distance isotropic deviations resolve with bifocal adds over the appropriate refractive correction for distance, it is a high AC by A ratio accommodative esotropia. And if the isotropic deviation at near fixation equals isotropic deviation at distance fixation and both are corrected with appropriate refractive correction, it is a normal AC by A ratio accommodative esotropia. But if there is no reduction of esotropia with refractive error correction in a patient with comitant esotropia without any monocular cause of significant visual loss, we take a history of whether the onset of esotropia was before 6 months of age, which will label the esotropia as an infantile esotropia. But if the onset of esotropia is after 6 months of age and the esotropia does not reduce with appropriate refractive correction, we try to establish whether there is any distance near asymmetry of the esodeviation. If the esodeviation at near is more than esodeviation at distance, it is labeled as spasm of near reflex, and if the esodeviation at distance is more than esodeviation at near, it is labeled as divergence insufficiency. We note here that in these two conditions there is no reduction of esotropia with cycloplegic refractive error correction. If distance and near esodeviations are similar and the onset is after 6 months of age and there is no reduction of esotropia with cycloplegic refractive error correction, we inquire about previous exotropia, which if present labels the esotropia as a consecutive esotropia. Otherwise, we have a patient with basic esotropia if the esotropia is constant, or cyclic if the periods of esotropia alternate with periods of orthotropia and these cycles are regularly repetitive. So among acquired non-accommodative esotropias, we have basic esotropia where we find similar esodeviations for distance and near fixation, cyclic esotropia in which there are alternating 12 to 36 hour periods of esotropia and orthotropia. During the orthotropic period in patients with cyclic esotropia, esodeviation cannot be induced by occlusion. Sensory esotropia caused by monocular visual loss, divergence insufficiency in which esotropia is more at distance than at near. This can be due to stretching of the intermuscular septum between lateral rectus and superior rectus muscles, which occur in elderly individuals and is called a sagging eye syndrome. Due to high myopia in young individuals, which is known as heavy eye syndrome, or due to intracranial lesions. Convergence excess or spasm of near reflex is also an acquired non-accommodative esotropia in which esotropia is more at near than at distance, and it is associated with stress and anxiety. Consecutive esotropia is also said to be an acquired non-accommodative esotropia, and it is the occurrence of esotropia following a period of exotropia. It can occur spontaneously or following surgical correction of exotropia. Incomitant esotropia can be due to 6th cranial nerve palsy, restriction of medial rectus muscle, or following placement of orbital implants. Thank you for listening.